So I'm Dale McMurchie and part of the Team Primary Care Secretariat. So welcome to our webinar series. The presentation today is entitled Considerations for Planning the Composition of Primary Care Teams. But before we get started, I would like to do the land acknowledgement. And as I read the land acknowledgement, I welcome those of you who are participating to drop into the chat where you're coming from as well today. So while we meet virtually, let us begin by acknowledging the ancestral territory of all First Nations, Inuit, and Métis peoples from coast to coast to coast upon which we meet today. We acknowledge the need to work collectively and individually to recognize the past and continued effects of colonialism and racism on Indigenous families, communities, and knowledge systems through the Indian Act, Indian residential schools, Indian hospitals, and other systematically discriminating policies, practices, and documentation. We affirm our responsibility as settlers to improve relationships between nations and actively seek greater understanding of Indigenous peoples and cultures in the communities in which we live, learn, work, and play. Please join us in this acknowledgement and commitment, each in our own way and through Team Primary Care, to move forward towards truth and reconciliation. So I'd like to introduce Sarah Simkin and Cynthia Damba, who are going to be presenting today. Sarah is a family practice anaesthetist and workforce researcher. She is the Health Workforce Planning Co-Lead for the Canadian Health Workforce Network and has been collaborating on primary care workforce planning with the Toronto region since 2017. Cynthia is the director of the Health Analytics team at Ontario Health Toronto. She's a trained physician and epidemiologist with planning experience in population health, health equity, primary care, health system measurement, and quality. Cynthia has been co-leading the primary care workforce project in collaboration with the Canadian Health Workforce Network since 2017. Over to you, Sarah. And just want to point out, Sarah is coming to you from Japan this morning. It's 2 a.m. So I want to give a special thank you for your providing this webinar to us this morning or afternoon, depending on where you are. Sarah.
No, thanks very much, Dale. Can you see my screen?
Yes.
Yeah.
Great. Okay. So thanks for having walked us through the Indigenous land acknowledgement and for introducing us. We are really thrilled to have the opportunity to give this webinar. Today, we're happy to share what we've learned through conducting integrated primary care workforce planning in Toronto. Today we'll first address why workforce planning is important and how it can help primary care teams. Next, we'll have a talk about what health workforce planning is and how one would start. Then we'll show you what planning looks like in practice, drawing some examples of planning outputs from Toronto and some testimonials from our partners. And finally, we'll end with some key points and have a chance for a short discussion and Q&A.
Thanks, Sarah. Can you talk just a little bit louder?
Yeah, I can just adjust the mic and see if that makes a difference. Is that any better? No? Hang on a sec.
No, that's better. Thank you.
That's better? Okay. All right. So first, why is workforce planning important and how can it help primary care teams? Why should we plan? Workforce planning is an international obligation. The World Health Organization recognizes the importance of planning And in its 2016 Global Strategy on Human Resources for Health, outlines 4 policy options and goals for WHO member states, including Canada. First, to optimize the health workforce to accelerate progress toward universal health coverage. Second, to understand and prepare for future needs of health systems, harnessing the rising demand in health labor markets to maximize job creation and economic growth. Third, to build the institutional capacity to implement this agenda. And fourth, to strengthen data on the health workforce for monitoring and ensuring accountability of implementation of both national strategies and the global strategy itself. Local planning helps move our country and our health systems toward the vision articulated by the WHO. The WHO recognizes planning as being important on a global scale, but there's a more immediate planning imperative. Because patients experience the health system through the health workforce, a focus on the workforce is central to responding to their needs, particularly amidst emerging challenges like the pandemic. For primary care, planning allows teams to identify and address local issues proactively and to develop, implement, and evaluate fit-for-purpose solutions. Ultimately, planning supports the quintuple aim and contributes to improving population health, enhancing the patient experience, reducing health system costs, supporting clinician well-being, and advancing health equity. Not only that, but planning helps to smooth out cycles of health practitioners' surplus and shortage. As our colleague Erin Freyer demonstrates in this figure, strategic intervention before the system experiences a supply crisis can modulate dramatic shifts in workforce capacity. Given that neither oversupply nor undersupply of primary care practitioners is a good thing for patients or for the practitioners themselves, planning should be the focus of primary care teams and health system leaders. So how can planning help primary care teams? Planning can help everyone involved in primary care understand the communities we serve and the resources we have available. In so doing, planning promotes equitable distribution of resources. Planning can help optimize alignment between needs and capacity and can facilitate a move from reactive to proactive decision-making. Finally, planning can help us evaluate the efficacy of interventions, keeping the things that work and dropping the things that don't. So, what do we mean when we talk about health workforce planning? The best definition of health workforce planning was laid out nearly 50 years ago by Hall and Maya in 1978. They define health workforce planning as the process of estimating the number of persons and the kind of knowledge, skills, and attitudes they need to achieve predetermined health targets and ultimately health status objectives. Such planning also involves specifying who is going to do what, when, where, how, and with what resources for what population groups or individuals, so that the knowledge and skills necessary for the adequate performance can be made available according to predetermined policies and time schedules. This planning must be a continuing and not a sporadic process, and it requires continuous monitoring and evaluation. We love this definition because it has everything important in it. When it comes to primary care, we have typically worked and planned in silos. But now that we are increasingly training and working in teams, planning needs to account for this. Planning can help to make sure that patient complexity and the primary care team configuration that evolves to respond is documented and aligned with community needs. To do this, we consider who does what, for whom, where, when, why, and how. Now that sounds easy, but the mechanics of team-based planning can be complicated, And planning with the team as the unit of analysis is an evolving science. We'll talk more about this later in the presentation. A key question that we often ask is, at what scale should we be planning?
Oops. Hopefully she will rejoin again. But in the meantime, I'm just going to share my screen. And Cynthia, perhaps while we're waiting for Sarah to rejoin, if you could continue on. Can everybody see my screen okay? Great. Okay, Cynthia, you're on mute, but way you go.
Okay, thanks. Let me know when Sarah is back. So she was just starting this slide about the key questions we ask around what scale should we be planning? And the answer, in our opinion, is that we should be planning at all scales. We should be planning at the pan-Canadian scale, at provincial and territorial scales, and at regional, local, and practice levels. The focus of planning will vary depending on the scale, from defining broad health system goals for the country to succession planning for a practice, and everything in between. But regardless of scale, planning should consider health and other community services collectively. Next slide, please.
I understand Sarah's back. So
okay.
Sarah, when you get your audio, I think she's just trying to get the audio going. So, but we'll just let her continue to work with her system. But Cynthia, continue.
Okay. So what are leading practices in health workforce planning? Planning should be evidence-informed, utilizing high-quality data to inform assessments of requirements, capacity, and alignment, recognizing the broader social, political, economic, and organizational contexts. Planning should be integrated, sector-focused, and multi-professional rather than revolving around single professions in isolation, and reflecting the reality that high-quality healthcare is delivered in teams. Planning should also be an interactive exercise that leverages both quantitative workforce data and qualitative workforce intelligence from key stakeholders to develop locally relevant plans that reflect the realities of the system. And finally, we should embed iterative cycles of workforce planning, evidence generation, and evaluation into health system design, decision-making processes, and allow for regular revisions of projections to enable course correction.
Great. Sarah, are you back with us? You're
I am. I apologize. I just
Great.
lost the connection.
Okay, away we go.
Okay, thanks so
Next
much.
slide.
I'll
I'll continue to advance slide.
Great. Great. In response to a need for primary care workforce planning in Toronto, we developed a fit-for-purpose workforce planning process. But it turns out that this process can be applied at any scale, to any sector or profession, and to address almost any health workforce-related issue. The process involves iterative cycles of horizon scanning, scenario generation, workforce modeling, and policy analysis. High quality and comprehensive data are needed to support planning, and data inputs may be quantitative or qualitative. Engagement is embedded in the process. The particulars, including who's engaged and what kind of modeling is undertaken, depend on the scale and the planning question at hand. Next slide. So how do we start planning? You might be asking. Next. Planning is a team sport. Who is on your team will depend on the scale of your planning and on the issues and questions to be addressed. Leverage your network to identify core planners, planning partners, and peripheral supporters. Within your organization, identify champions of planning, individuals who know the community and its needs, and key stakeholders, such as data stewards, who may be able to help. Experience with analytics, education, communication is an asset, but honestly, being forward-thinking, data-minded, and having a belief in planning is all you really need to get started. Once you have an idea of who will be involved in planning and are ready to start, it's important to define the scope and goals of the planning exercise. First, identify the question or questions that need to be addressed. For example, what priority populations does our team serve and what are their unique needs? Next, consider the goals that the planning process should support. For example, you may develop a statement of purpose. If we use the first questions as an example, the statement of purpose may be, our goal is to ensure that our patients receive timely access to the primary care services that meet their needs. Then, you may need to go further with delineating the question, particularly with respect to geography and units of analysis. For example, who are the patients being served? Is the patient population geographically bound or unified by some other characteristic? What does timely access mean? Is access measured by how long it takes to get an appointment or some other way? And what primary care services are our patients likely to need? Can we consider all of these to be within the scope of the question? Finally, how do your planning activities intersect with activities underway elsewhere? For example, will decisions that you make for your community and patients have unintended consequences for neighboring primary care teams? Once you've clarified the problem at hand and its considerations, then you can examine the resources that will be required to undertake planning. Considering a few key questions is worthwhile. First, who will be engaged? Involving stakeholders, including patients, early in the process can pay dividends later, particularly by improving the quality of the planning and the credibility and acceptability of the outputs. Next, what financial, human, and technical resources will be required? Planning is an investment and should be approached as such. Also important are what data are needed. Are these data available? Note that data may be available at the geographic level, but not necessarily at the level of who is being served, which might impact how easy it is to address the questions at hand. What data access requests need to be submitted or processes followed is another thing you need to understand. And finally, how much time will be invested? Here's a hint, it almost always takes longer than we think it will. Next slide. Further to delineating the bounds of the planning exercise, it's worthwhile to give some consideration to the sector. It's safe to say that primary care is a broad undertaking and that primary care teams can be quite variable. And so it's important to clarify what services are of greatest interest. For example, are we talking about preventive care, about diabetes care, mental health services, perinatal care, or some other service that falls within the typical primary care basket? What definitions are of interest? What disciplines are of interest? So who can provide those services? In some cases, only one practitioner can deliver, but in others, there's overlap. Finally, what's the structure and mix of practitioners and tasks? This can be highly variable and dependent on what patients in the community need, who is on the team and their skills and interests, how the team has historically worked, and how funding flows for the service. Other key considerations include what are the factors that influence population health needs and service requirements? What are the factors that influence the workforce service capacity? And what policy levers are available to influence these factors? Considering these questions makes the planning process more comprehensive and more robust. A little bit of workforce modeling can help to support decision-making for primary care teams. And by modeling, I don't necessarily mean advanced analytics. The basic components of modeling are actually quite simple: defining the population and identifying needs, and defining the workforce and identifying capacity. To do this, we ask questions such as, who are your patients? What services do they need? How many services do they need? And Who's in your workforce? What skills do they have? What services do they provide? Who can provide which services? Modeling can help us look at the balance between the needs of the population and the capacity of the workforce, how they align, and the gap between the two, both now and in the future. Once a current or potential future gap has been identified, interventions to remediate surpluses or deficits can be explored. Here are the things that primary care teams need to do in order to actualize planning. Intentionally build capacity for planning. Commit to doing it right and adopting leading practices. Set aside time and funding. Assemble a team with the skills that are needed. Seek input from stakeholders and experts. Prioritize a data-driven approach and advocate for high-quality data and data infrastructure. Planning is not a one-off process. You will need to plan regularly and iteratively and to collaborate with adjacent teams and other sectors. By connecting with others doing the same work, you can build a planning community and help create a patient-centered health system in which decisions are made proactively rather than reactively. So what does planning look like in practice? I'm going to turn the floor over to Cynthia, who will tell you about integrated primary care planning in Toronto and show you some of the outputs that we've generated to support planning and decision-making there. Cynthia?
Thanks, Sarah. So in Ontario Health, Toronto region, we have been engaged in a primary care workforce planning project with the Canadian Health Workforce Network, as mentioned earlier, since 2017. This work stemmed from a need to address disparities in access to integrated primary care across the city of Toronto. Ontario Health Toronto recognized a gap in workforce planning and that system stakeholders needed support to make evidence-based decisions, particularly with regards to equitable deployment of the workforce and other health system resources. Primary care health human resources planning has been a priority for the City of Toronto and Toronto region for some time, but has recently become even more important due to the changes in primary care landscape that has been exacerbated by the COVID-19 pandemic. Challenges which you all know of include increasing demand for primary care due to population growth, increasing for patient complexity, physician burnout, early retirement, and low levels of primary care attachment that disproportionately affect marginalized and racialized groups. So really, proactive workforce planning is needed to address these challenges. And at Toronto region, you see our map, we plan usually at a neighborhood level, given a very diverse population. And we have the sub-regions, which will provide examples coming up. Next. So through a phased approach, we have developed our health workforce planning toolkit that includes a fit-for-purpose qualitative planning model for Toronto region. It focuses on population growth, patient mobility, and physician retirement. The toolkit provides a body of evidence around current and projected future states of the population health needs and primary care service provision at neighborhood level. We are currently in the third phase of the project, and one of the main components is to build capacity for primary care planning in the region and beyond. We are engaging with 5 of our OHTs, Ontario Health teams, and providing tools to support and enhance readiness for planning. Throughout this process, we have the support of a team primary care developmental evaluation, who will be developing a how-to playbook for planning. This playbook will be a resource for the OHTs who are not part of this project and other stakeholders who are doing primary care planning. Next. So here are some examples of our planning landscape. As I mentioned earlier, population growth is one of the key factors affecting the need for primary care in our region. You can see from this map that Toronto neighborhoods are expected to experience different levels of growth in the next 10 years, with some having minimum growth and others expected to have significant growth due to new residential and commercial building projects. Estimated population growth range from 0%, that's the lightest blue areas, to 460% in the next 10 years. Those are the darkest blue areas. So really proactive planning is needed to make sure that infrastructure to meet the primary care needs of growing neighborhoods is in place. Next slide, please. This slide comes from one of the work we are doing for one of our OHTs, the primary care engagement we are doing with one of our OHTs. So examining marginalization indices at the sub-region level can help to identify high needs neighborhoods and communities, where additional primary care and other resources can be allocated. Using the Ontario Marginalization Data Tool, we look at 4 domains related to age and labor force, household and dwellings, material resources, racialized and newcomer populations. This matrix view gives us a community level view and allows us to explore marginalization by neighborhood or by dimension. You can see the variation in marginalization across the 4 marginalization domains across North York Central neighborhoods. Darker browns indicate higher marginalization, while green indicates areas with the least marginalization. There are some high needs neighborhoods which show high levels of marginalization for all the 4 domains. Next. In addition, understanding community burden of disease can help to direct efforts to support better patients, to better support patients and practitioners. In Toronto, we examine prevalence of asthma, COPD, diabetes, hypertension, mental health and addictions, and multimorbidities. That is, people having 2 or more chronic conditions or 4 or more chronic conditions. In this chart, you can see the variation in prevalence of patients with 2 or more chronic conditions across North York Central sub-region neighborhoods. The proportion of patients with multimorbidity ranges from a low of 7% to a high of 21%. That's triple the rates in the highest neighborhood. 3 neighborhoods in particular have the highest rates, including Victoria Village, Bunbury, Don Mills, and Hillcrest Village. And these are particularly relevant for team-based care. Next. Examining attachment rates can help to focus efforts to connect patients to primary care. The map shows variation in unattachment rates across Toronto neighborhoods, with the darker red areas having higher proportions of patients not attached to a primary care provider. And the graph assembles unattachment data for patients in the North York Central subregion and shows that rates of patients who are unattached in these neighborhoods range from 15% to 23%. Next slide, please. It is also important to understand what professional resources are available in an area and where they can help to create teams that respond to community needs. This table shows the availability of 13 allied health professions across North York Central sub-region neighborhoods. Some neighborhoods are well served by allied health, while others, such as Victoria Village, Pleasant View, and Willowdale West, lack services from several professions. Those are the ones which have had a lot of pinks, the nose. Documenting the presence and absence of allied health is useful, but in addition to determining whether services are available, one needs to know how much allied health services is available in order to have a comprehensive assessment of capacity. When we consider all the factors we have presented so far, it happens that Victoria Village in these North York Central neighborhoods, which is the neighborhood with the highest rate of multimorbidity you saw earlier in the slide, also has higher rate of marginalization and unattached patients, and the least allied health support as shown in this slide. And hence, this is an area that needs to be targeted for team-based care enhancements. We also looked at age-related retirement probabilities and defined retirement probability thresholds to plug primary care visits that are potentially at risk as a result of physician retirement. This approach allows us to identify neighborhoods where physicians might retire, as well as the potential magnitude of the impact of retirement on the community. The graph shows that for this neighborhood, between 2018 and 2023, overall physician capacity is projected to decrease over time, likely due to aging physician workforce. And at the same time, the proportion of visits that are at risk, shown in red, increased from 1/4 in 2018 to almost 2/3 in 2023. This neighborhood may need to be the focus of efforts to retain older physicians in the workforce or to recruit new physicians. So to support primary care planning across the region, we have developed an interactive planning process that guides users through 6 sequential steps: understanding community characteristics, understanding service requirements, understanding workforce service capacity, assessing alignment, exploring the factors at play, and putting it all together. Users can walk through each step for a given neighborhood or choose to focus on a single step across multiple neighborhoods. We're also developing the functionality that will allow whole city and sub-region level views, exploration of population growth and retirement scenarios, and trends over time, as well as comparison of communities. As we expand the outputs of the model, the results will be added to step 5. The dashboard is still in development, but we are going to give you a snapshot of what each step looks like so that you have a sense of the potential power of this approach to support planning. Next. So in step 1, we assemble data related to population size, age structure, health status, marginalization, health service utilization, primary care attachment, and other relevant community characteristics. We can compare neighborhood indicators with city benchmarks. And the panel on the right offers a narrative summary with takeaways tailored to the selected neighborhood. Next. In step 2, we estimate total service requirements for each neighborhood. We take patient mobility into account and break down service requirements into visits required for residents of a given neighborhood, for residents of other neighborhoods, and for patients from outside the city who use services in that neighborhood. In this neighborhood, which is growing, service requirements are expected to increase over time. Most of the care in this neighborhood is provided to patients from other neighborhoods, the middle green portion of the bars. Next slide. In step 3, we look at the characteristics and capacity of the primary care workforce, including physicians and 16 allied health professions. We focus on physician service capacity in the form of primary care visits, and we plug service capacity that is at risk to physician retirement, as I explained in an earlier slide. In this neighborhood, the workforce is aging, and we estimate that almost half of all service capacity could be at risk due to physician retirement. Next. In step 4, we bring together service requirements and service capacity and assess the alignment between the two. The gap and how it is expected to change over time can inform decision-making and resource allocation. In this neighborhood, service requirements are expected to increase that is the blue line going up, while service capacity is expected to decrease over time, that is the black line. Knowing this in advance allows decision makers to anticipate issues with access to primary care and to mobilize resources. So in step 5, we offer opportunities to explore things that are relevant to planning, such as population growth, population mobility, physician retirement, and physician retirement. Users can also look at trends over time and compare indicators across neighborhoods. Some of these modules are still in development, but we hope to have them included in the dashboard soon. The last step of step 6 is bringing everything together. By presenting information about population characteristics, growth, mobility, workforce resources, visits due to retirement, and anticipated gaps between service requirements and service capacity, we offer an integrated look at what is happening in the neighborhood. We also offer links to resources and potential solutions. So, as I mentioned earlier, we are currently engaging 5 of our OHTs in Toronto region to build capacity for primary care workforce planning, given that they are charged with primary care planning and coordination and building primary care networks in their areas. We are holding individual sessions with each OHT and sharing with them data packages from the primary care workforce toolkit, as well as reviewing local issues with them. I'll leave you with some of the quotes from the OHT leaders about the value of primary care planning and toolkit resources. Here's one. One of our partners says, and it really is a driver of Ontario Health teamwork to think about how we are going to get the healthcare workers that we need to actually deliver integrated care. How do we train them to support them? We need this to drive change. You need to have this level of information to help with not only population health planning, but then you know concurrently the workforce that's going to be needed for that. So that's why we decided to engage, and that's why this is really exciting, because it's going to help our OHT be successful. Next slide. Some other quotes are, thank you so much for this toolkit. It's certainly raised our capabilities to do planning in primary care, and we've used it quite a bit, and I really, really appreciate it. So thank you for this work. Another quote is, this work is not just useful, it's vital to the work that we do in keeping the system alive. So, and now I will turn the floor back to Sarah to sum up and leave you with some key points.
Thanks so much, Cynthia. The first key point is that we hope you'll take away is that we need to embed health workforce planning into ongoing health system decision-making at all scales, including the level of the primary care team. Better planning allows for a proactive rather than reactive approach to health system challenges. Leading practices, such as the ones we've outlined today and given you examples of, should guide health workforce planning activities. And finally, planning supports team-based care by mobilizing critical information related to needs and capacity. Please consider us as a resource to support primary care team-based workforce planning. Don't hesitate to reach out to us if you need support. Next slide. Here's how you can contact us. We'll now open the floor for questions and have a short discussion.
Thank you so much, Cynthia and Sarah. Imagine a world where we planned for the primary care health workforce in this manner. Just stop for a minute and think what that would be like. Cynthia and Sarah are open to some questions. So I know that was a lot of information and really inspiring. Victoria.
In fact, it's Maxine with Victoria from Quebec City. I had a question regarding what is the level at the ministry, or I'm trying to see which level have you done this work, because we're a clinic, so that's for one thing. And so it obviously would not do this planning at our level, but I'm also medical advisor at the ministry. So I'm wondering at which, should it be at the Montreal level? Should it be at the Quebec provincial level? I'd like to hear you about what is the level you've done this work so far.
Cynthia, do you want to take that one? Do you want me to start and fill in?
Yeah, please do. Thanks.
Okay, I'll start, and then Cynthia will fill in the blanks. So when we first started, the level was regional, which is the city of Toronto, which is several million people, 140, now 158 neighborhoods, 11, now 14 different subregions. And while regional is important, and there are certain regional questions that we're addressing with this, we also realize that there's so much diversity across the region that planning has to be done more locally as well. And so in this phase, we've taken the scale of planning down to the Ontario Health Team level, which is probably collections of practices to support collections of neighborhoods and communities.
But what level do you work? Where are you? Who pays you? If I may, just I'm trying to see which direction at the Quebec Health Ministry should be tackling this work.
Well, so there's the Toronto region, part of Ontario Health, and they have made this a priority. And then they have asked for our expertise. So we're involved in the capacity of consultation and co-development.
From the Ministry of Ontario?
From Ontario Health Toronto region.
Okay, thank you.
Cynthia, can you help me?
Yeah, and maybe even Ivy may step in. Ontario Health, Toronto, Ontario is divided into 6 regions for planning. We are one of them, Ontario Health Toronto, and our jurisdiction is the City of Toronto. And there are 5 others. We do local planning, and as Sarah said, we have Ontario Health teams that are smaller groupings that are charged with coordination of primary care as well as other services for their areas, attributable population and also geographic population. So we have partnered with the Canadian Health Workforce Network, as Sarah said, over these years, to help us build our planning capacity and this toolkit which you are seeing. We funded them originally, and now and we've been doing this in phases. The last phase now, which we are in, is funded by Team Primary Care, and hence how come we're participating here. However, we have been reflecting back and sharing the information we have with our colleagues in other regions, in Ontario Health region and at a provincial level. We've also shared with some others from the Ministry of Health, and we just collaborate with them to obtain, with different partners, to obtain data. So Ministry is one of our data partners. They provide some data for this, as well as so many other groups of partners. So that's sort of how we roll up. And Ivy, please jump in.
Yeah, so this work is in part a labor of love, right? So the earlier work, there has been a lot of support that was provided, earlier in 2017 and 18, with a contract with Ontario Health, but we saw the opportunity to get this work done. So Team Primary Care provided support, for Sarah's time. Cynthia and the team at Ontario Health, that's additional support that they've provided, sort of in-kind support. So everything goes towards populating the data for the quantitative side, conferring with the different community members. But this is not within the ministry, the political side. This is within the service side. So I understand that that's kind of combined a bit more with MSS in Quebec. So it would really be, so it doesn't necessarily have to be with the service side. This just happens to be, where we are doing this. So for example, there's some interest in Alberta Health, again, the service side, not the ministry within Alberta. And we are looking at doing something at a municipal level, right? So we think that Toronto was a really good scale for integrated primary care because it's so complex. So I would suggest, if I was asked, that planning at the Montreal or Quebec City or particular regions would be the best scale to do this.
Thanks. Andrea, you had your hand up. You're good? Okay. IVO.
Thanks so much for the presentation, Sarah and Cynthia. I've been waiting longingly for this presentation to understand more of the work. My question for you is, in order to help link your work with the others that are doing other projects on Team Primary Care, one of the things that we've been struggling with is articulating what are the services, clinical domains affiliated with primary care. So when you use in your toolkit, what are the services? Do you have a set criteria or we used to have the PCAR basket in Ontario. Is there a nomenclature of what are the services that primary care actually offers? That's one question, because that's one of the things that we're trying to come together for consensus on, and maybe a place that we can come together upon. And then with those services, I think the other is when you say who are the healthcare workers that are there, the other element that we're doing is trying to connect. Well, if these are the services, who are the healthcare workers that could potentially provide these services if they were given the training or upskilled to actually do that training? And I'm wondering how you define in your planning tool healthcare workers. Are they the ones that are potential that can provide the services, or are they the ones that actually are currently providing those services? And then going back to who's defining what those services are.
Okay, maybe I'll start, or do you want to start, Cynthia?
No, go ahead, Sarah.
Okay, thanks for the question, Ivy. So you asked a bunch of questions all at once. So why don't we start with what are the services? So in order to do modeling, we needed to choose a unit of analysis that we had data about on the population side and on the workforce side. And so our modeling is built around primary care physician visits. So that is the core of this particular model, although the principle of what are the needs of the population, what is the capability of the workforce is applicable beyond just primary care visits. And eventually our goal would be to build out our modeling to all of the different practitioners and services that are being provided in Toronto. So that leads me to the second kind of set of questions that you ask is who are those? And we went through a really extensive process to identify the 16 allied health professional groups that are included in the data cut that you saw there, we consulted with our community partners, with our city partners, with our data steward partners. We went back and forth with the Ministry of Health, who holds the health professions database where the information that we tapped into comes from. And we eventually settled on a list of 16 different professions. And now that we've taken the scale from the region where it makes sense to look at, do we have this allied health profession present in a given community or not, and about how much services that are they providing. Now that we're starting to engage with Ontario health teams, we're looking hopefully to do more localized, what do you actually need service-wise? Who do you have providing those services? Who could you shift to provide those services, who's already trained to do that, what's within their scope, that kind of thing on a more local level. And it needs to be done that way because needs are so variable that there isn't one, in Toronto anyway, we don't feel that there is one size that fits all in terms of here are the needs, here are the services, here are the practitioners who can do that. And so it happens locally. Cynthia, I'm sure there's more you can add to that.
Yeah, so yeah, thanks, Sarah. That was great. Maybe what I can add is around defining primary care. We had, as Sarah said, we engaged, our data partners, ICES and others, and ministry, and we first started off with looking at what is defined as comprehensive primary care. For Ontario, this is a basket. These are physicians who provide a basket of services. There's an algorithm that the ministry uses and also ICES uses to define what comprehensive primary care services are. And we had first included just this group of primary care physicians who provide comprehensive primary care. But then as we kept looking at the data, we realized we were missing so many physicians who may not actually meet the full criteria of comprehensive primary care. And we see that becoming more relevant now with more physicians, changing practice and moving away a bit from primary care to other focused practices and stuff. So in our data analysis, we have included visits for physicians who provide comprehensive primary care as well as non-comprehensive care.
Thank you, Cynthia. Sarah, there's a question in the chat, and I'll read it out, but just so you can take a look at it as well. So the question is from Manon. When analyzing the slide depicting various levels of engagement, OHT, regional, provincial, pan-Canadian, how is the team actively collaborating with healthcare organizations such as CIHI and CMA to effectively break down silos within the healthcare industry, particularly in the context of work underway with health workforce planning?
Yeah, great question. So maybe I'll start, and then Ivy might be able to fill in. So we actively collaborate with CIHI because we're using the CIHI population grouping methodology to help with quantifying service requirements. And so we have done a lot of work with them around their tool, understanding it and how to apply it, sharing with them how we've used it, which has been particularly interesting to them. Now that we are doing a second go around, we're going to be able to test how accurate their projections using the population, or our projections using the population grouping methodology have been. We haven't engaged that much with the CMA, but at the Canadian Health Workforce Network, we are working on multiple fronts to break down some of these barriers, along with the other work that we do outside of of this project. Ivy?
Yeah, so I added some of that as well into the chat. So right now this is focused on Toronto, so it's really building on Toronto level data, of which a lot of that is standardized, particularly on the population side, using the CHI Pop Grouper, for example, which is a tool that anybody can use across Canada. You know, Toronto has invested in a lot of population side data, and Ontario has invested in a health professions database, which collects 59 data elements that are standardized across a number of different providers, which is a reason why we can have standardized data on the allied professions that, you know, were identified through this consultation process that Sarah noted. You know, timely access to data and kind of pulling it all together into this toolkit is a challenge. So that's really notable. We are also working with CHI to kind of accelerate the adoption of their minimum data standard. And we're working on, through a CHR project, enhancements to that data standard built on the insights that we've garnered from doing this 5 years of planning with Toronto, because you want to make sure that you have data fit for planning purposes. And so anytime that you can standardize data, the better that it enables you to do integrated planning across practitioner group in a location and across jurisdictions. So both of those things are the reasons for data standardization. As Sarah mentioned, we've had a couple of conversations with the CMA Integrated Health Human Resources team, and also with the two teams that they have on physician health and integrated health human resources, and the connections between that, because we need to better plan for the workforce to better support them so that they have a much more manageable workload and working together, etc. So all of those things are connected. So those would be things that I would add.
Thank you, Ivy. And Kathy in the chat made a very important point as it relates to those of us in primary care. Really need to be thinking about a population health basis, what community-based services are required. And our perspective around health workforce planning could also be expanded to the health neighborhood and all of those services which work closely with primary care. And so that's another critical point to think about in terms of our health workforce planning. Any other questions before we wrap up? Thank you so much, Sarah and Cynthia. Oh, go ahead.
No, there's a question in the chat from, or maybe it's been answered. Sorry, that's okay.
Okay. Well, thank you both. I did drop the emails and the website into the chat for people who would like to reach out to Sarah and Cynthia. Much appreciated for putting this inspirational presentation together, and we all look forward to a world where this is the way in which we plan for the health workforce in primary care. Thanks so much, everyone, and have a wonderful afternoon.